All right, Red Nation. Today we're going to be talking about cardiac CT. This is an area that's been really hot in CT imaging for the last 20 years and is an area where the vendors really try and show off as far as the technology such that they can image the beating heart. As you can imagine, imaging the beating heart is going to be one of the most difficult challenges from a temporal resolution perspective on the system. So we're going to talk all about how cardiac CT works, different options you have for scan modes for doing cardiac CT, and also about temporal resolution on the system, which is very important in the context of cardiac CT. Coming up here at How Radiology Works. So as your heart is beating, the idea is that we can do CT images in order to look at the coronaries, look at the whole heart, look at the valves, all these different applications within cardiac CT. And the idea behind cardiac CT is we want to find when the heart doesn't move as much, and then we want to image quickly. If you're interested, you can look up what's called the Wiggers diagram online. This has a general information behind the cardiac anatomy. High level, the heart is beating in what's called a cyclical pattern, and we're going to use some extra information in order to do what we call gating of the scan, such that we use the projection data that corresponds to the area that has the least amount of motion. So if we look at right here, this is actually a plot of the volume of the left ventricle over time. And if you think about the volume, it's filling with blood and then it ejects blood, filling with blood and ejects blood. And as it's moving, that's when you don't want to do imaging. So as the volume's changing, that's when you wouldn't want to do imaging, because that's when there's going to be motion. When it's relatively quiescent or not moving, that's when you do want to do the imaging. If you look at it here, you can see there's one portion here that might be okay to do imaging in, and then there's a portion up here which looks even better to do imaging in. This is for a relatively normal heart rate. And in general, for most moderate and lower heart rate patients, imaging during the diastolic region is preferred. So we want to image in here where there's less motion. And how can we identify the area there's less motion? We're actually going to use another signal, and it's actually the electrical signal. So there's an electrical signal, and you're probably familiar with ECG or EKG if you're in Germany. In the heart, there's actually an electrical signal that's generated in order to tell the heart to do the contraction. And this is what's called the QRS complex here. It's the biggest measurable peak in the electrical signal. So in CT imaging, we typically are just talking about the R waves. These are the areas that are most easy to measure in our electrical signal. So we go from one R wave to the next R wave. And then we look usually at a fractional percentage along that R to R interval. So often in CT imaging, we're just talking about imaging somewhere in here around 75% of the R to R interval. And that is in what we call the peak diastolic period. So that's right in here. Once that's the case, you can see how you do this on your scanner. You also have an interface which looks like this, where you see an R peak, and then you have the window over which you're going to be doing your imaging. Then we ask the question, what's the minimum scan range we need in order to acquire the complete amount of data to make our CT image? So at a high level, you can think about if we had parallel beams coming from this direction. You can see our video on filtered back projection if you want to see what parallel beams look like. If we had parallel beams coming from this direction, and then if we had parallel beams coming from this direction here, if we kind of ignore the beam hardening artifacts that we talked about in our last video, we can see that that is actually the same data. So the rays passing from one direction are the same as the rays passing from the other direction. And thus, if we have 180 degrees of what we call parallel beam data, that's enough. And beyond that, we have just what we call redundancy, or measurements of additional data, but it's not really required in order to make our CT image. So we need 180 degrees of parallel beam data. So how much data do we actually need from our system? Our system doesn't acquire parallel beam data, it acquires what we call fan beam data. So the data comes out in this direction, see our video on 3rd generation CT if you're interested in that general geometry, but at a high level, it's coming out like this from the source. And then our detector is along an arc down here. And then the fan angle is essentially the angle covered by the detector. So the amount of data we actually need is 180 degrees plus the fan angle. If we have 180 degrees plus the fan angle, then we're going to be able to rebin into parallel beams, and we can get 180 degrees of parallel beam data. If we talk about the weighting function that we're going to use, the projections are going to be weighted as a function of view angle, and in the center they're going to have a higher weight, and at the edge they're going to have a lower weight. The width of that function is actually 180 degrees at the center. So what we call the full width half max is actually 180 degrees. So from that perspective, what we talk about is what's the effective temporal resolution of cardiac CT. If you have a single X-ray tube and detector on the gantry, it's actually approximately the rotation time divided by 2.
High pitch, medium pitch, low pitch.
So low pitch helical scanning was the first way that cardiac CT was actually performed. And in this case, it's actually gated by the ECG signal that we talked about. And each little segment actually has a relatively low pitch, so it's very close to actually an axial acquisition. So you can do reconstruction, which is very similar to axial reconstruction for this low pitch helical data. In that scenario, you can do gating, like we talked about, getting essentially a short scan of data, and you can do that such that for each slab of data, you will be able to reconstruct at the same cardiac phase. Then the assumption here for the low pitch case is that the heartbeat is repeatable, so that as you're going through, you're going to need many different slabs, maybe 7 slabs in order to image the whole heart, or potentially more. And as you're going through, you're doing each of those slabs. The assumption is if you're at the same point in the ECG signal, that your heart will be in the same position. If that's not the case, you'll see some differences, and we call those slab artifacts, or artifacts at the interface between the different slabs. Multi-slab axial was introduced next, and in multi-slab axial, the idea is that you would go around the patient and you could potentially scan the heart in a series of 3 axial acquisitions. So this is called usually 3-beat cardiac. Sometimes it would take 4 beats depending on the coverage of those axial slabs. But the idea here is that you could save radiation dose because in the case of helical, that was very low pitch. And because we are looking at prioritizing the gating, we're actually going to not be using the data that's far away from that given heartbeat. That's different than traditional helical reconstruction, where there are opportunities to use redundant data. In the case of cardiac reconstruction, you're typically using the minimum amount of data available. So the helical acquisition for cardiac is relatively dose inefficient. So the multi-slab axial was a big improvement in dose efficiency. You still can have those same artifacts at the boundaries between the different slabs in multi-slab axial. And there's a concept on a dual source scanner of a high pitch acquisition. So on the dual source scanner, you actually can think of 2 different helices because there's 2 sources and 2 detectors. So as those 2 different helices travel around the patient, you can actually have a higher pitch than if you just had 1 source and detector combination. So in this scenario, the Siemens Healthineers have introduced what they call the turbo flash, and they have a flash mode specifically for cardiac, where you can do prospective gating. If the heart rate is relatively stable, you can actually gate so that you have the table motion starting ahead of time, and then you will image the volume using this high pitch helical acquisition. So in this scenario, you actually aren't doing the same gating where everything in the volume is at one given phase. In this scenario, you're just reconstructing based on the data that you have, in more of a typical helical acquisition. So in that scenario, you're actually changing the phase as you move down in the volume. As the data range is changing, you're changing the cardiac phase because the position that you acquired the data at is actually linked to the time. Then finally, we have wide cone axial scanning. So if you were to design a cardiac specific acquisition, it would most likely look like this kind of wide cone axial scan because you can cover the whole heart in one beat and you're going to have freedom as far as the phases that you can acquire. So the wide cone axial is really optimal from the perspective of covering the whole heart within one beat. The different things that we talked about, banding artifacts, those traditionally will occur on either the low pitch helical mode or on the multi-slab axial mode. You would not have significant banding on either the wide cone axial or on the fast helical acquisition that's prospectively gated, because in both of those cases, you're only using one given beat in order to make that image volume. Then as far as the phase consistency, like we talked about, if you assume that the object is going to come back to the same location, then the low pitch helical, the multi-slab axial, those are both going to be at a consistent phase. And the wide cone axial, you actually don't have to have that assumption in order to get an image which is at one given phase. In the case of the fast helical acquisition, it's intentionally not going to be at the same phase, such that you would optimize the image quality of each of the slices independently, but they would be at a changing phase with respect to one another. As far as dynamic imaging, if you want to image and make a movie or make measurements in the systolic and diastolic phase to look at something like ejection fraction, if you're looking at that kind of dynamic imaging as a function of the different phase, it's going to be, again, dependent on that assumption. If it's repeatable, if the heart is returning to the exact same spot, you're actually going to do okay with the low pitch helical or with the multi-slab axial. When that's not the case, you're going to have banding artifacts. And in the wide cone axial, you actually don't have this assumption again, and you are able to do the dynamic imaging. And this is not possible with that fast helical acquisition because you don't have the ability to do multiple phases of reconstruction. And if you're looking to image the lungs as well, and you want a full field of view, in this scenario, if you don't have the dual source and you do a low pitch helical or you do an axial scan, you'll be able to get the full field of view. If you are using the dual source, there's going to be a constraint on the field of view based on the size of the second detector, and then also based on the fact that you're doing a fast helical acquisition. If you're using wide cone axial, you will not have a constraint on the field of view. So like we talked about, the temporal resolution of a single source scanner, you're going to be able to say is approximately the rotation time for one time around divided by 2. Then you can kind of heuristically do that again for a dual source scanner and divide that again by a factor of 2. But even though the dual source scanner does have the shortest temporal window to take the acquisition, there are still residual motion artifacts. You can see that here if you look at the left ventricle. Actually, you can see there are significant residual motion artifacts during the acquisition itself. And you can see in simulations that were done at GE, if you look at the coronary artery, this is a simulation of a coronary artery moving at the same velocity. On the left is a single source acquisition, on the right is a dual source acquisition. And in both scenarios, you can see there's a significant tail here. So this tail is due to the actual motion that was occurring during the acquisition. So if there is motion of the coronary, if you don't have an actual quiescent period, what will actually happen depends upon the direction of that motion with respect to the source. But in this case, you can see this tail here. And in the case of a dual source system, you're actually going to have 2 tails that are going to be added together with one another, but those tails are each significantly shorter. So there's actually less of a span of the artifacts, but you can see that there is not the ability to take a perfect image. Even with dual source scanning, there is potentially still motion artifacts. We believe that motion correction should be used to optimize the image quality on all scanners. And just like how cameras have both a fast acquisition, then they also have software in order to help reduce the motion artifacts. Motion artifacts can be significantly mitigated in CT scanning as well. The first product to do so was called Snapshot Freeze. This was introduced by GE Healthcare about 10 years ago now in 2012. The idea here is that we actually take multiple images. So we make one image at the center phase, we make one image a little bit earlier and one image a little bit later. In the original Snapshot Freeze, we would identify the coronary tree. And the original Snapshot Freeze is actually just working to improve the reconstruction quality in the coronaries. After the coronary tree is identified, then the areas where the coronaries are will actually track the motion based on those 3 images, and then we will do a motion compensation such that we can get images with significantly improved coronaries. Since that time, some of the other vendors have also added solutions. So Canon has a solution that's coronary specific here, and then Philips has a solution also, which is coronary specific. So Philips was more recently FDA approved, and Canon's has been out for some time as well. So if you look at the correction for these algorithms, as long as there is good opacification in the vessels, they can be detected. And you can see here the vessel quality, especially in the RCA, which is your fastest moving vessel, especially for higher heart rates. This is a case of a 70 beats per minute. This is an 80 beats per minute patient. You can really appreciate the improvement in the coronary image reconstruction. Think about a simple test that you could perform. You could actually think about having motion and then a stationary period and then motion again, and have that motion be a linear motion, velocity set there based on the literature. And you also want to consider different motion orientations. If you haven't seen our video about motion artifacts, check out our video about motion artifacts in CT, and you'll see why there's really a strong dependence on the direction of the motion and the types of artifacts that you're going to get. We looked at 4 different directions of motion and then at different resting times. So if you look at it as a function of resting time, here is a artery, and then we had a little calcification within the artery. And this is before we did a segmentation on this side here, and this is after we did a segmentation. And then on the left in each panel is the straight filtered back projection result, and on the right is after the motion compensation. So you can see that as your resting period gets smaller, there's going to be more and more motion blur occurring in the images. And if you do just straight filtered back projection, the object really gets spread out significantly, such that it's really tough to differentiate how much of that object is actually the calcification versus how much of that object is actually the vessel. It's also the case that you want to have a system which is robust with respect to the direction of motion, because the systems in general don't control the angle at which the X-ray tube goes on and off. The idea is just to take the image at the right phase, and so the angle is something that you actually don't have control over. So we want to be robust with respect to the different angles. So if you look at just filtered back projection, you can see there's some directions where there's relatively little difference, and then there's some directions where there is significant difference. But if you look at the motion correction case, it's significantly improved. And you could make plots of the error, and this is basically a mean error over all those vessels. You can also look at the variability, standard deviation with respect to those vessels. So namely, how different are they going to be if it's moving in different directions? Both the error and the variability are significantly reduced, and they're very stable in the case of the motion correction. All those solutions that I talked about before, those are all coronary specific. So then GE was the first also to introduce a whole heart solution, which goes beyond the coronaries and looks at valves, looks at implants, and this is the whole heart solution. And so you can see here before the correction and after the correction, there's a significant improvement in the image quality. Because there's so much improvement with these algorithms, there's actually an effective temporal resolution, which is about 24 milliseconds in the case of these images in comparison with the native images, which if it was taken at 0.28 second gantry, the native reconstruction would be about 140 milliseconds. Over a cohort of patients, you want to see that your vessels are consistently interpretable such that you can actually perform your diagnosis. And before having the Snapshot Freeze 2, if you looked at just the native reconstruction, 92% of the vessel segments were interpretable. And then over 99% of the vessel segments were interpretable with the Snapshot 2 freeze correction. So this to appreciate the clinical benefit that you can have in terms of more vessel segments being interpreted, you really need to try these types of corrections out in clinical practice. Next, check out our video on motion artifacts in X-ray and CT in order to really understand why we have these motion blurs and artifacts in our X-ray and CT images. Coming up.